Good morning and good afternoon, everyone, and welcome. I'm Ingrid Skuman, a TB survivor and chair of the Union's Community Advisory Panel at the International Union Against TB and Lung Disease, also known as the Union. Welcome to this official scientific press conference that we hope will build on the tone set at yesterday's press conference. As my colleague Guy Marks remarked yesterday, these are indeed challenging times for the global TB response. But I certainly share his sentiments that we are seeing a significant scientific shift around the disease. Diagnostics are getting smarter, and the pandemic is also driving renewed interest around infectious disease transmission and indeed the use of face masks. New technologies are moving the goalposts around discovery. I'm looking forward to hearing today on the results involving some studies around AI and genome sequencing. We are also gaining heart in recent years from the rapid improvements in more effective and shorter treatment regimens, and I'm delighted that we'll be hearing some great news on that front in today's press conference. With that, let's get started. Before introducing my esteemed guest sitting here with me, let's run through some of the housekeeping. This live press conference is being recorded and will be available on the conference YouTube page shortly after it has ended. Today, we will be hearing brief remarks from all our speakers. Then I will open it up for questions from our media representatives attending today. So to ask a question, please send it via the question and answer function at the bottom of the screen. Please indicate your media outlet and who you would like to direct the question to. We will then direct the question to the nominated panelists. If you want to ask a question verbally, please indicate that too, so that we can turn on your microphone. Please keep your questions brief. Okay, with that, let's begin. Our first speaker today is Fleming Lue. Fleming is an investigator at Shenzhen Ying Medical Imaging in Guangdong, China. He'll speak today on some exciting research involving AI for screening active TB on CT images. Over to you, Fleming.
Hi, first of all, it is my pleasure and honor to participate in this scientific press conference by the Union. This work has been conducted since 2018 with the support of several hospitals in China and also in collaboration with the partners in the US, such as the National Library of Medicine and the University of Texas and the MS Technologies. The motivation to have such work is CT has been installed widely in rural hospital for diagnosis and the screening tuberculosis in China. However, experienced radiologists, professional, are very lacking. Also because the CT has been recommended for diagnosis of COVID-19, so lots of additional work has been made for healthcare providers to provide service so it makes the healthcare professional work even harder. So therefore, we developed an automatic detection system based on AI in the study to improve the diagnostic accuracy for active TB. This study involved, because of it's artificial intelligence, so involved the training and the testing. So this study involved close to 900 CT studies with about 475 TB and mixed with the non-TB pneumonia and the normal cases for training. Then the developed AI system would be tested in a smaller sample set, about 670 cases, which involve about 550 TB and the rest of normal and non-TB pneumonia cases. Our independent test shows that the AI can successfully diagnose the active TB, and also can show a good differentiation between the TB and the pneumonia. So actually, we think this AI will be function as a second pair of eyes. So in other words, it doesn't really replace the human, but it will provide the references for the healthcare providers, professional as a references. So then they were going to make a final diagnosis. So although this is a study, it's a very small amount of data, but we think this small data will lay the good groundwork for the future for the AI in the large clinical evaluations and the clinical trials, and also can simplify the diagnosis process. Now, we also hope that the success of this effort will really benefit the different stakeholders like patients, healthcare providers, professionals, and even vaccine and drug development organizations and the policymakers in order to help to reach the goal to eliminate TB. In the end, we are very willing to collaborate further with any different organizations to further improve the algorithm to conduct more clinical testing, integrate with the clinical settings and workflow. So thank you again for this opportunity to share with our initial results and receive feedback. Thank you.
Thank you, Fleming. Our next speaker is Arturo Torres Ortiz. Arturo is a PhD student at Imperial College in London in the UK and will talk today about his study involving genome sequencing pre-resistant TB. Go ahead, Arturo.
Hi, everyone. Thank you, Ingrid, for the nice introduction. As you said, I'm a PhD student at Imperial College London at the group of Dr. Louis Grandjean. But most of our research in tuberculosis is actually based in Peru, in Lima, where, as you probably know, there's a huge proportion of multi-drug resistant and extensively drug-resistant tuberculosis. In the past decade, and we have got a huge catalog of mutations that we can use to tell apart what is drug-susceptible tuberculosis and what is drug-resistant tuberculosis. What we wanted to go is a step farther from that, or a step back, and focus not in drug-resistant tuberculosis, but in drug-susceptible tuberculosis, and try to figure out whether we can find and identify some genetic markers in drug-susceptible tuberculosis that can tell us whether a bacteria is more at risk of becoming resistant. So to do that, we collected in 2009, back in 2009, we collected population level sampling around 3,000 samples of basically everyone who came to the health clinics with signs of tuberculosis. We got an X-ray and we got a sputum sample from them, and we sequenced every single one of them. As I said, that amounted to about 3,000 samples. That included many drug-resistant, but also drug-susceptible. This differentiates this data set from the most common data sets in that we don't enrich our sampling for drug-resistant. We have a sample from everyone who came to the clinic. And what we wanted to figure out is whether we could find any signs in drug-susceptible bacteria that will become resistant in the future. And we identified those signatures at 3 levels. First one, the tuberculosis lineage. In Peru, we have lineage 2 and lineage 4. And what we found is that lineage 2 tend to acquire resistance much faster and at a higher risk than lineage 4. What we also found is that the resistant background also matters, meaning once the bacteria acquires resistance to one antibiotic, it is more likely that they will keep acquiring resistance to more antibiotics. We tested that with isoniazid, and what we found is that once the bacteria acquire isoniazid monoresistant, then it's up to 15 times more likely to acquire further resistance to rifampicin. And third, we tried to identify specific polymorphisms that we can use perhaps to make a molecular test in the future that can tell us whether this susceptible bacteria will become resistant in the future. And we found specific polymorphisms. For example, we found a polymorphism in LPPP gene, which is a protein that the bacteria uses to interact with the immune system of the host, and that seem to be quite associated to future drug resistance. So now that we have this, of course, we would like to go a step further, validate these findings in like bigger global sets, and perhaps even cohort studies.
Thank you, Arturo. This is truly exciting work and a potential game changer for preventing MDR TB. Let's now continue on the theme of prevention. All too often, despite TB in children with pneumonia being common, its diagnosis is often missed or delayed. And our next speaker, Olivia Marti, is the research director at the Bordeaux Population Health Center at the University of Bordeaux in France. And he will present some encouraging results around a trial using molecular testing for TB in children with severe pneumonia in countries with high TB incidence. Go ahead, Olivia.
Thank you, Ingrid. Thanks to the organizer for the opportunity to tell you about our results on behalf of the TB Speed Consortium, a whole group who is working on this problem. We will present the results on TB Speed Pneumonia, a study that has been funded by Unitaid and the initiative. And as you reminded us, the question is, in a context where we know the large proportion of children are not diagnosed for TB, because the diagnosis is more complex in children. And this is really the cause of mortality. Most children who die from TB die because they do not access treatment because they are not diagnosed. And the question is raised as we know more and more that TB is also frequent in children with pneumonia. Pneumonia is an acute disease. It's the largest cause of death in children. And as most doctors, we've been taught that TB is a chronic disease that develops through weeks and so in children with pneumonia, most people do not think about TB. They think that children may have TB if they have repeated treatment failures or if the cough has been present for long. So our idea with the TB Speed group was to offer systematic molecular testing for TB in all children with pneumonia. And to see whether it would be feasible, which means that children would be able to have this testing, and whether it would impact mortality. Of note, for children, it's not like in adults where you can do molecular testing on a sputum sample, a sputum that is rather easy to expectorate in adults. In children, notably below the age of 5, they are absolutely unable to expectorate. So you have to use sample collection methods that are easier. Usually we use gastric aspirates, which are quite invasive. You have to put a tube in the nose of the child down to the stomach. So it requires hospitalization. So with the TB Speed group, our idea was to use easier sample collection methods, stool samples and nasopharyngeal aspirate. We just have to put a small tube in the nose of the child and reach the back throat, I would say, but it's rather easy. So we did this in the TB Speed Pneumonia study. We did this study from March 2019 to March 2021 in 15 hospitals from 6 high incidence countries: Côte d'Ivoire, Cameroon, Uganda, Mozambique, Zambia, and 1 country in Southeast Asia, Cambodia. We enrolled overall in those 2 years with a 6-month break due to the COVID pandemic, where we were unable to run the study. We enrolled 1,169 children in the group where we apply the intervention. We try to do this nasopharyngeal aspirate, stool testing, and molecular testing using the Expert Ultra. We were able, in those children with severe pneumonia, to collect samples in 97% of children, to collect nasopharyngeal aspirates. And in 81%, we were able to collect stools. Although stool samples seem rather easy in children, it takes time to collect stools, and it's not as easy as for nasopharyngeal aspirates. Most of these samples were tested in the hospitals with the gene expert, the expert ultra, the molecular test, and it resulted in 24 children out of 1,169, so 2% with a positive TB test. And in addition, the work with the doctors led to having 89 children overall diagnosed with TB, so 8% of this big group diagnosed with TB. It's really important findings because although we have more and more data showing that TB is frequent in this group, the guidelines for now and the practices are not taking really this information into consideration. So we need to have better tools to detect TB in this group. It's notably important because children with severe pneumonia, they require oxygen, they have dyspnea, and showing that nasopharyngeal aspirates are feasible and do not cause harm in those children is very important to convince doctors around the world that they can use this technique to diagnose TB in children. We will show also during this conference how this impacted mortality in this group and how it was acceptable from the parents or the nurses' point of view to do this type of sample collection in very young children who are hospitalized for severe disease. So everybody is a bit worried about the implication for the clinical status of the child. This is what I wanted to report on our results. Thank you.
Thank you for sharing these interesting findings, Olivia. So now we'll shift our focus to treatment. Grace Muzanye is the clinical coordinator at the Uganda Case Western Reserve University Research Collaboration in Kampala, Uganda. Grace will talk about the results of a trial carried out in collaboration with the CDC in the US, looking at the efficacy and safety of a 4-month rifampicin moxifloxacin regimen for TB in adolescent participants. Go ahead, Grace.
Thank you, Ingrid, for the opportunity to address the world press. I'm Dr. Grace Muzanye from the TB Trials Consortium site, Kampala, Uganda, which is part of the Uganda Case Western Reserve University Research Collaboration. So I'm briefing you on the efficacy and safety of a 4-month high-dose rifampicin moxifloxacin containing regimen in the treatment of TB of adolescent research participants. In the year 2016 through the year 2019, the TB Trials Consortium under the Division for TB Elimination of the U.S. Center for Disease Control and Prevention, in partnership with the AIDS Clinical Trials Group, conducted an open-label, large, multi-center international trial assessing the efficacy and safety of 2 4-month high-dose rifampicin containing regimens with or without moxifloxacin for the treatment of pulmonary TB in patients. And the efficacy of these 2 experimental regimens was compared to the standard 6-month regimen of TB in terms of curing TB. So the result coming up from this large international trial, we found that the high-dose 4-month rifampicin moxifloxacin containing regimen was not inferior to the current standard 6-month regimen of treating TB. And at the same time, we found that this regimen was safe in all the patients that were randomized and treated with this regimen. Now, this same study allowed the enrollment of adolescent patients who were aged between the age 12 and 17 years old. Now, with this background, we are very curious to find out if this regimen, the 4-month high-dose rifampicin moxifloxacin containing regimen, was not inferior to the standard in the whole study. How about the population of these young people, the adolescents, who were aged 12 and 17 years old? So we were driven to go ahead and conduct an analysis looking at the safety and efficacy of this same regimen in this group of patients. The initial primary endpoints we had for the main study was being free of TB disease 12 months from the time you are enrolled into the study. And then there was a safety endpoint as well, where we are looking at the proportion of patients enrolled who had grade 3 adverse events and above. So we use the same endpoints for the adolescent population analysis. So there were 10 international sites in 7 countries that enrolled adolescents in this study. There were sites in Africa, sites in Asia, and sites in North America, and sites in South America. Now, for the main study, we randomized more than 2,500 participants and enrolled all these randomized into the study. And of these, 68 participants turned out to be adolescents. So this was the population of adolescents in this study. Then we went ahead and did the efficacy and safety analysis for the adolescent population. Now, our finding regarding efficacy analysis, we found that the high dose 4-month high dose rifapentine moxifloxacin containing regimen was still found to be non-inferior to the standard 6-month regimen of TB treatment. And also, this regimen was found to be safe in adolescents. And this turned out to be an eye-opener to us in 3 ways. Number 1 being that it's now feasible to enroll adolescents into clinical trials, as we saw in this study that we did. You know, previously many studies have been kind of dodging enrolling young people like adolescents into trials. They start from age cut of 18 and above. Now this study shows that we are now, it's very feasible to enroll adolescents into these studies. And number 2, we have now such seriously considering enrolling adolescents into future clinical trials as well, as seen in this study. And then number 3, it really showed us that we can use this 4-month high-dose rifapentine moxifloxacin containing regimen to treat TB in adolescents. The numbers of adolescents in this study were small. We may need more data, but the way things look at the moment, we can use this regimen to treat TB in adolescents. Thank you very much, Ingrid. I think in summary, that is the kind of work we did.
Thank you, Grace. That is very encouraging findings, especially, like you say, for the younger population. The results of our final study today, I know, have been much anticipated for many working in the field of MDR-TB. TB Practical is the first ever multi-country randomized controlled clinical trial to report on the efficacy and safety of a 6-month all-oral regimen for rifampicin-resistant TB, also known as RR-TB. The Médecins Sans Frontières results are being presented in a symposium on the BPAL regimen on Thursday, where I understand we'll also hear about Ukraine becoming the first country to implement operational research of TB Alliance's BPAL regimen, the 6-month regimen for most difficult to treat forms of TB. To summarize the MSF results, I'd like to introduce Bern Thomas Nyanga. Bern is the chief investigator of the TB Practical trial and the medical director of MSF in the UK. Over to you, Bern.
Thank you, Ingrid. Good morning, good afternoon, or good evening, wherever you are. As introduced, my name is Bern, and I'm the chief investigator of the TB Practical trial. And I'm sharing you the results of the TB Practical trial on behalf of more than 200 colleagues that have been working on this clinical trial over the past 9 years. We have around 17 collaborating institutions that have contributed to the results today. So as you know, rifampicin-resistant TB, or which is managed in the same way as multi-drug-resistant TB, currently is treated by 9 to 24 months treatment that contains up to 15-20 pills a day that patients have to take almost daily. And the global results at the moment are just over 1 in 2 patients have a successful treatment outcome. TB Practical is a multi-arm, multi-stage, open-label phase 2-3 randomized controlled clinical trial that evaluated the safety and efficacy of 24-week regimens that contained bedaquiline, pretomanid, and linezolid for the treatment of pulmonary rifampicin-resistant tuberculosis. The trial comprised of 3 investigational arms and a control arm. And this morning, we are reporting results from the 2-arm phase of the trial, which is the final stage of the trial. And as Ingrid has mentioned, we will report the detailed results on Friday in a symposium from 2 p.m. Central European Time. In the TB practical trial, we enrolled individuals from 15 years of age with rifampicin-resistant TB from sites in Uzbekistan, in Belarus, and in South Africa. Patients with quinolone resistance, also known as pre-XDR TB patients, were also included in the trial. Those with HIV infection were included irrespective of the CD4 count. Patients were randomized to either the practical arm 1, the BPAM arm, which was for the patients to receive around 5 pills of bedaquiline, pretomanid, tapered dose linezolid, and moxifloxacin daily, or the control arm, which was a locally approved standard of care regimen. This is a non-inferiority trial with a 12% non-inferiority margin. Now, the results of the trial, we included 552 participants in the trial, but at this point in the stage 2 of the trial, we have 279 participants that are included in our modified to treat population. The primary analysis was assessed at 72 weeks post-randomization. So the favorable outcome was reported in 88.7% of participants in the BPAM arm, so the arm that received bedaquiline, pretomanid, linezolid, and moxifloxacin. This was in comparison to 51.5% of participants who received the standard of care arm. This represents a risk difference of a minus 37.2%, or a risk ratio of 0.23, which we can also say it's 80% relative risk reduction. As this was a non-inferiority trial, we made the analysis on both non-inferiority, and when this was reached, we also then did an analysis on superiority. So the results mentioned earlier demonstrated both non-inferiority and superiority in the modified intention to treat population with a p-value of less than 0.0001. The non-inferiority was demonstrated in the per-protocol population as well, with a p-value of less than 0.001. There are no deaths, failures, or recurrences in the BPAM arm. The results were also consistent in the subgroup analysis when we adjusted for HIV status at baseline, cavitation on chest X-ray, sputum smear status, and whether the patient was quinolone resistant or not. From the safety perspective, participants taking the BPAM regimen had a 19.4% grade 3 and above adverse events. This was compared to 58.9% in those taking the standard of care arm. And we also showed that QTc prolongation, which was quite a concern at the beginning, was significantly lower at 24 weeks in the BPAM arm. The conclusion from this is that we feel we have shown, using a gold standard methodology as a randomized controlled trial, that a maximum of 6 months treatment for rifampicin-resistant MDR TB and pre-XDR TB is feasible with the BPAM regimen. We were able to show that the 24-week BPAM regimen was non-inferior to the locally approved 9 to 24-month standard of care regimens for the treatment of pulmonary rifampicin-resistant TB. And we also demonstrated that the combination of pretormanid, bedaquiline, and moxifloxacin at normal doses, as well as tapered dose linezolid, was safe. Data are being shared with the WHO for the upcoming GRTB guidelines review. And we're very willing to share more details with national TB programs that would be interested, as well as other global organizations that are working in TB. Thank you.
Thank you, Ben. I think all of us would agree that these are tremendous results. And now we will be happy to take any questions. So just a reminder, please type your question in the Q&A function at the top of your screen, indicate the media outlet and whom you'd like to address the question to, or whether you would want to ask the question verbally. And with that, we can begin. So we already have one question for Dr. Nyanga from Marcus Lowe from Spotlight. How much did the standard of care in the TB practical differ in the different countries? And how did the BPAL regimen do compared specifically to the all-oral short treatment regimen used in South Africa?
Okay, thank you for the question. So the standard of care, as we mentioned, was adjusted to the locally approved. So when we designed the trial, our aim was to ensure that if patients, if the country moved on to an improved standard of care, and you might know that this trial started in 2017, and therefore over time there have been some improvements. So we made sure that if there was some improvement in the standard of care in the country that we were recruiting from, then we also ensured that in the trial we aligned to that. So in terms of outcomes, the standard of care, we have done the subgroup analysis looking at that. There are minor differences in terms of outcomes across the different sites, but the main results are not different by country. And the BPAL regimen, I'm assuming it's looking at the early access plans that are being done. The main difference with that, the BPAL that we are using is that we include the 4 drugs, bedaquiline, pretormanid, linezolid, and moxifloxacin, which is not in the BPAL arm. And also the other key difference is that the linezolid dosing, we give 600 milligrams of linezolid for the first 4 months of treatment and reduce that to 300 milligrams for the remaining 2 months. And that we consider to be the right dosing to reduce the risk of toxicity that we know linezolid tends to be of concern. Thanks.
Thank you, Dr. Nyanga. And also please feel free to ask follow-up questions, any of the media representatives. While listening to the studies, as the XDR TB survivor, I would like to learn more if Arturo could maybe share how you engaged with community advisory boards and make sure that civil society understands and participate in the process of research projects. Thank you.
Hi, thank you for the question. So one of the characteristics that Peru has is that it has a very, very strong public health tuberculosis program. And so basically, I did not do any of the sample collection. I didn't do any of the engagement with the public, and everything we do it in collaboration with the public health department there in Peru. I don't know if that answers the question. Sorry, I'm probably not the best one to answer the question, as I took most of the care of the of the statistical analysis and not so much sample collection, but everything, as I say, everything we do it in collaboration with the public health department in Peru, and yeah.
Thank you. Fleming, can I ask you, what do you think could be done to increase the acceptability or the uptake of using newer AI to screen TB, and what barriers still need to be overcome?
Yeah, thank you for the question. I think AI, okay, it's because to detect TB, we need to have, want to make sure, go through the evidence-based trial, and want to further improve, because we only test a small sample set, although the sample set is really independent from the training set. So the AI, just like a student, the more cases you train them, okay, the more cases you teach the medical students, they're going to learn more. So and then we select the cases which has been confirmed with a spit and smear and some diagnostic report, some gene expert too, but those are still small amount of cases. So I think some of the barriers are, one thing is the training cases. We need to have more training cases to train the AI algorithm. Then another one is, once it's been trained, okay, we want to validate that, just like lots of medical devices. We want really this become evidence-based. We want to publish that those has been tested, they're being evaluated by different clinical sites to make sure the performance will meet the requirement. Another one is we also hope this can be used. So will be another important thing is if different country or they have the communication, they have a communication. So even they don't have the physician in the local rural areas, okay, they can still send the images, okay, through the network, internet secure network, to the AI processing centers, so AI can create the references for the rural area to, for them to take appropriate actions. So I think those are the things we need to do. Yeah, thank you.
Thank you, Fleming. Olivia, could you maybe share next steps planned by your project team with us?
Yes, thank you, Ingrid. The TB speed pneumonia study, in fact, is just one component of the TB speed project that is a large project funded by Untitled. And I told you about testing this new approach based on nasopharyngeal aspirate and stool samples in children with pneumonia. When we started the project, these samples were not yet recommended. They were very innovative. Now they have just been recommended by the WHO for implementation in children with presumptive TB, based on some results from TB Speed and other groups. So we are also testing this strategy in children with HIV, in children with severe acute malnutrition, and in 6 countries, Sierra Leone, Côte d'Ivoire, Cameroon, Uganda, Mozambique, and Cambodia. We are testing those strategies at very low level of healthcare in primary health centers. And the study just ended. We screen up to 150,000 children, and those who were identified with presumptive TB through a very simple question-based screening at triage, they benefited from this approach. So we just finished enrollment. So as you see, with this, with testing this strategy in different groups of children with different vulnerability, we are hoping to provide more evidence to NTPs and clinicians and colleagues and nurses in the field on how to improve the molecular diagnosis of TB in children, and to have this really implemented at the lowest level of healthcare, as you know, where children attend care, for the first time. So these are the next steps.
Fantastic, thank you. Arturo, could you share your project's next steps with us?
Yes, of course. So I think, as I pointed out before, what the first immediate step will be to validate and to add more of these genomic signatures in a more global, publicly available data set. Right now, there's thousands and thousands of whole genome sequences that are publicly available that we can use to our benefit. So we can like validate some of the hits that we got and also add some more. We're also working on laboratory confirmation. So we would like to see, for example, with fluctuation assays, whether we can see some of these differences that we find between tuberculosis with the mutations that we detect and tuberculosis with without the mutations that we detect, and validate in the laboratory whether they truly acquire resistance faster. And then once all that is done, we can do many other studies, for example, follow-up studies of patients that we know were had tuberculosis with the mutations that we're interested in, and follow up with them over time to see whether they're acquiring resistance or whether they remain susceptible. And maybe later on we can even prepare cohort studies and more control studies.
Great, thank you. Grace, could I ask you, when you are working with adolescents, can you tell us about how you communicate and how the messaging is done so that when they participate in the study, that the messaging is at the right level? So how do you as a researcher engage with the target study population? Thank you.
Thank you, Ingrid. All right, so engagement of adolescent population in our settings is at different levels. To begin with, we have a community engagement group at our site and actually across the TBTC, the TB Trials Consortium. And these link the research sites with the communities. They go out to the communities, organize public sensitization campaigns, and then speak out the entry criteria of the different protocols that may be actually looking for adolescents as well. So the adolescents come on board with their parents. We go on, talk to their parents as well. And then we go through the assent and consent process, and they end up being enrolled into the studies. Now, just from some experience that we learned, this enrolling adolescents, but also keeping them on the study. Once you've enrolled them, sometimes becomes a challenge. And what you have to be sure about is the locality where they come from and which people are their guardians. And you have to engage the guardians, you have to talk to the guardians as well. But of course, not against the will of the adolescents themselves as well. They should be willing to be in the study. It shouldn't be like the guardian said, yes, I've given you a green light, go ahead and enroll this adolescent, and they think, oh, then it's okay, your guardian says so and so. No, you have to say yes. And the guardian also has to say yes, and then you end up enrolling them and keeping them on study. Now, we had a challenge as well. We enrolled adolescents, we're in school. And now most schools, don't allow TB cases in there within, TB being contagious. They don't allow children with TB being within the school premises. So that was a challenge initially, but what we did there was to involve the parents and the school administration, have these kids return home for the initial 2 weeks, have treatment for at least 2 weeks. When we knew they were no longer infectious, not again anymore to the rest of the kids in the school, then all of them returned to school. And when say they return to school, for example, we had to engage the school nurse because these drugs were being given as directly observed, and the school nurse was giving drugs to these children. And then they would get special permission from the schools to return to our center, our research center, for evaluation and look for any complications of treatment and adverse events in them. So the whole thing is a multi-level thing, engagement of these adolescents, both at the parent or guardian level, and then maybe the social institution they are in. Those are the schools, and of course, the community advisory board that is linked to us as a research center.
Thank you, Grace. I would like to hand over to Bern, as you wanted to expand on the first question that was asked from Marcus Lowe. Over to you, Bern.
Thank you, Ingrid. And I just wanted to expand because maybe the response was much more general, and you had asked specifically around South Africa. And I wanted to be more specific on that, as of course, South Africa, we had sites in South Africa as well in the trial. So just to clarify that in our subgroup analysis, there were all of the 3 countries at country level, there was no difference. So in a sense, the regimen was still shown to be non-inferior when we did the subgroup analysis for each one of the countries. In addition to that, we also know that in the trial, we included between 30 and 50% of patients on a shorter regimen. I recognize that some of it could have been the shorter regimen with injectables, but in South Africa, because the country moved quite quickly away from that, we would have included a significant proportion from South Africa would have been on a shorter oral regimen. And still, in that sense, we still see that this regimen did well in comparison to the standard of care. Thanks.
Thank you, Ben. So that's all the time we have for today. Thank you very much for everyone who joined us. And please approach Michael Kessler from the Union Communication team if you want to follow up with any of our speakers. Thank you very much for joining, and enjoy the conference.
Thank you very much.